Breast reduction refers to a group of surgical procedures, the goal of which is to reduce the volume and therefore the weight of a woman's breasts. In doing so, it elevates and tightens the skin envelope, lifts the nipple, reduces the size of the areola, and produces a more youthful shape. Most women seeking breast reduction surgery are trying to alleviate the symptoms they feel from large and often very heavy breasts. Common symptoms include neck ache, backache, shoulder pain, grooves in the shoulders from their bra straps, and even a rash under the breasts. That's called intertrigo. It's quite common in the summer months. Many women will complain of difficulty getting clothes to fit properly, and most have problems with exercise, particularly activities such as running and gym work. There's quite a social stigma attached to very large breasts, and some women feel very self-conscious about how they look, particularly the mismatch between their breasts and the rest of their body. Among plastic surgery procedures, breast reduction remains one of those with the highest satisfaction rate. Women of all ages who are suffering from the usual symptoms related to large breasts are potentially candidates for breast reduction. Most plastic surgeons don't offer this type of surgery to patients who are still smoking because nicotine is a very significant risk factor for complications. Similarly, a high BMI is associated with a higher complication rate, and in my practice, women who present with a BMI over 32 will be asked to lose weight before they're considered suitable for surgery. Girls under the age of 18 will need to have a letter of support from their GP or school psychologist confirming that they're mature enough to understand the surgery, its risks, and on the rare occasion that complications occur, are able to deal with those complications. Patients who are still smoking are not candidates for breast reduction surgery because the risks of the surgery remain very high. Patients will need to stop smoking in my practice for at least 4 weeks, preferably 6 weeks, before they're considered a candidate for breast reduction surgery. Nicotine remains one of the highest risk factors for things such as nipple necrosis, that's death of the nipple, infections and wound breakdown, particularly at the areas known as the T-junction, which is where the different scars meet each other. Patients who are still breastfeeding are not candidates for breast reduction surgery, and I request that they've stopped breastfeeding for at least 3 and preferably 6 months before they consider this surgery. Patients who are considering becoming pregnant again in the near future are also advised to wait until their next pregnancy before they consider breast reduction surgery, though it's not necessary for patients to have finished their families before having this type of surgery, as long as they're prepared for revision surgery should it be required if things change after pregnancy and breastfeeding. Patients who are not a candidate for general anaesthetic can't be offered breast reduction surgery, since the surgery needs to be performed under a general anaesthetic and can take as long as 2.5 to 3 hours. Patients who are not prepared to have scars on or around their breasts are obviously not candidates for this type of surgery either. Though most women with very large breasts are keen to proceed with breast reduction surgery as soon as they can get it, they should generally wait until they're physically and mentally ready to proceed. That means that they should be at or close to their goal weight. Preferably they should have finished their families, and if not, they shouldn't be planning to breastfeed in the near future. Women who are very keen on breastfeeding and don't want to interrupt that potential should defer breast reduction surgery until their families are complete. Patients who are still smoking should stop for at least 6 weeks, and anyone over the age of 40 should have a mammogram, firstly to confirm that everything's okay, and secondly to provide a baseline against which future scans can be compared. Patients seeking information on breast reduction surgery can find a lot of resources online. Websites such as Real Self, plastic surgery websites, and the website of the Australian Society of Plastic Surgeons has a lot of information on this type of surgery. My own website has got a number of articles and blogs, as well as patient photographs who've undergone breast reduction surgery if they want to see representative outcomes. Patients considering the surgery can contact my staff and we'll set them up on a program called TouchMD, through which we can give them information such as this on the surgery and what to expect afterwards. After surgery, I meet the patients in the patient reception area where I mark out their skin, indicating where I'm going to place the nipple and where the skin cuts are going to be made. Last minute questions can be addressed at that stage. The patient's then wheeled into the operating theatre where they're put to sleep and the surgery commenced. The surgery usually takes around 2 hours. Drains are inserted into the wounds intraoperatively, which allow drainage of the fluid into a bottle that's kept by the side of the bed. These drains are usually removed in the first 24 hours and always before the patients leave. Any pain relief is usually prescribed by the anaesthetists, and patients who have specific requirements for post-operative pain should address those requirements with the anaesthetist either pre-operatively or afterwards. All prescriptions for pain relief and antibiotics are provided by the anaesthetist and given to the patient on discharge. In my hands, breast reduction surgery takes anywhere between 1.5 and 2.5 hours. At the end of the procedure, the patients stay for another 30 to 40 minutes in recovery before being wheeled up to the ward. They usually just stay one night in hospital, but very occasionally, patients will require a second night before going home. There's a variety of techniques for breast reduction, but in my practice, the most reliable and predictable technique involves a scar around the areola, a scar down from the areola, and a scar in the groove under the breast. That's called a WISE pattern. The pedicle that I use, that is the tissue that's kept attached to the nipple as it's moved up to its final position, in my practice that comes from the supromedial area so that the blood supply is very reliable and safe. Surgeons can't guarantee a cup size from breast reduction surgery, and most surgeons, including myself, will try and make the breasts small enough so that they completely relieve the patient of the symptoms that they present with, while still providing nice proportions with their body and their hips. Many women will say, I want to be as small as I can, and some women even come in saying, just make me a B cup. In some cases, that'll be way too small for the patient when you consider their overall build, particularly their waist, their shoulders and their hips. Generally speaking, in my practice, most patients will end up a C cup or a D cup. It's very rare to make them smaller than a C or larger than a D. Though some patients do request to be left fuller breast, and a double D cup is probably a more appropriate size for the very larger girls, most patients will end up in that C to D cup range. Patients having had breast reduction surgery are usually in hospital for just one night. After that, I usually ask them to rest, relax and recover at home for the first 2 weeks. That basically involves not driving and not doing anything too exertional for that period of time. So no exercise, no gym work, try and keep housework to a minimum, try not to raise their arms above their shoulders, and for the first 4 weeks they have to wear a compression bra. Sometimes I push that out to 6 weeks depending on the patient. From 2 weeks to 4 weeks they can generally return to light exercise, light activities, driving. Most women can go back to desk-based jobs at that period of time. It might take another couple of weeks before patients who are in very physical jobs can return to work, and about the 6-week mark they should look and feel pretty much back to normal, except obviously with their smaller breasts. So from the time of surgery to the time of feeling completely normal is probably around 6 weeks. Scar management commences at the time of the surgery. The dressings that are placed on at the end of the operation need to be kept clean and dry. Allowing these to get moist increases the risks of infection, which therefore increases the risks of poor scars. The dressings are usually removed at the first post-operative visit, and scar management is then discussed with the patient. This may involve either a combination of light treatments and silicone, or silicone alone. This can usually commence at around the 2 to 3 week mark. Until that time, patients should keep their wounds clean, should dry them well after showering, and should apply bio-oil or a similar emollient. From 2 to 3 weeks after the surgery, light-based therapy such as Heal Light, which is what we usually recommend, and topical silicone can commence, and that should continue until around the 3 to 6 month mark, depending on the appearance of the scars at each stage. Patients should expect the scars to take 12 to 18 months to fully soften and become pale. In some cases at that stage, the scars can be hard to see, though patients need to know that there will always be some scarring visible. Breast reduction surgery is very safe, and fortunately the complication rate from breast reduction surgery is very low. However, all surgical procedures carry risks, and breast reduction is no exception to that rule. There are general risks associated with any operative procedure, and they include things like bleeding, bruising, wound infections, the potential for healing problems or bad scars, the possibility that the breasts might not be identical to each other, or that the patient might experience a collection of blood or fluid inside the breasts. Rarely there are anaesthetic complications, including clots in the legs, clots in the lungs, and issues with the anaesthesia that could in fact be life-threatening. To date, I've never experienced any significant complications from breast reduction surgery. The specific risks of breast reduction include things like nipple necrosis. Now that's where the blood supply to the nipple is interrupted and the nipple can die. To date, I've never had a patient that the nipple has died, though I have had some patients with very, very large reductions where the blood supply hasn't been adequate completely for a few days and some of the surface skin has occasionally been lost. This has never caused any significant issues with the cosmetic or functional appearance of the breasts. Other potential risks include sensory changes to the nipple, which although common are usually quite transient, and most patients will have relatively normal feeling by around the 3 to 6 month mark. Dog ears are little puffy bits at the end of the scars, and usually they'll settle down by the 12-month mark. If they don't, then often they can be removed under a local anaesthetic, and that doesn't cost the patients anything if they have private health insurance. Bottoming out is a condition where the weight of the fat inside the breast exceeds the stretching capacity of the skin, and so the skin tends to stretch in the bottom of the breast and the weight of the breast drops. That causes a heavy appearance to the bottom of the breast, and very occasionally that requires a revision to reduce the weight of the bottom of the breast. And once again, I don't charge patients for that, although it has nothing to do with how the surgery was performed. Finally, patients can experience something called fat necrosis, where the fat or the gland that's left behind doesn't have a rich and healthy blood supply, and they can present sometimes with tender lumps in the breast. Often that'll settle down and the lumps may well disappear, but it can take a little bit of time, up to a couple of years, for that to happen. Regardless of the procedure that we are planning, the first consultation with me is usually an information gathering and education exercise. That involves taking a detailed history from the patient, including their medical history, any medications they're on, especially blood thinners, whether they're a diabetic or a smoker. I usually ask whether they have a family history of anything that's relevant to the surgery, and that includes a family history of bleeding or clotting problems. I then perform a detailed examination and, wherever necessary, take measurements which are documented in the patient's file. The rest of the consultation is usually spent outlining the procedure and what to expect in terms of the operation itself, the recovery afterwards, and the risks of the procedure. The consultation ends with me giving the patient some work to do at home, and that usually involves a series of documents in the TouchMD portal where they tick the boxes to just ensure that they have understood everything that I've said and have no further questions. There's usually a checklist of things that people have to go through before the surgery if they elect to proceed, and that just makes sure they don't forget anything.